Hi everyone, we have another Pecha Kucha session, so it will be exciting. So I'm Mona Nasser. I'm a professor at the University of Plymouth and the director of Plymouth Institute of Health and Care Research. I don't think I have to go again around how the Pecha Kucha work, all of you know, but just reminding people, you will be voting at the end for your favorites, so keep a note of it, please. So we have a range of exciting talks like before, and the first one is Abhishek Ghosh from the Postgraduate Institute of Medical Education and Research from India. Like, Abhishek, we're looking forward to you.
Good morning, everyone. We'll start now. Oh, no. So I am very excited to present at the GFBR platform. I'm an addiction psychiatrist from India. I will focus on the mental health research priority settings, especially in Indian context. I will delve into the ethical opportunities and challenges in research priority setting, in particularly in mental health and particularly in the context of India. Although this presentation pertains to India, but I guess the other LMICs will also find it relatable. The information regarding the magnitude of the problem of mental health burden in India comes from two major sources. The National Mental Health Survey, which is conducted in 22 Indian states, discovered 10.6% of the current mental morbidity in India and a treatment gap of up to 90%, indicating a dire need for service delivery. The second source of information is a global burden of disease study, which revealed like 197 million people with mental morbidities in India, which is almost equal to 14% of the Indian population. And the disability-adjusted life years attributable to mental illness has almost doubled in the last 3 decades. So you'd expect a proportionate amount of budget will be allocated to mental health, but sadly that's not the case. Only 2.1% of the Indian GDP goes to healthcare, and of it, only 0.15% goes to mental health care. And this 0.15% is not mental health research, it also includes service delivery to a large extent. So I have spoken about the resource constraint in overall healthcare, which further accentuated the constraint in the mental health care budget. And of course, when the size of the pie is small, then the research priority settings become an important exercise. On the left side of the screen, you could see the top 10 disability-causing conditions for India in 2019. Mental health conditions do not figure in that list. So these competing priorities, coupled with the resource constraint, might actually enable the decision maker to reduce the size of the mental health care pie further. I will delve into 3 major ethical challenges in research priority setting. The first one is regarding transparency. Transparency is about, as you all know, making everything public, the research priority exercise, the processes and the reasons to be made public. And the second is regarding inclusiveness. Inclusiveness is about authentic engagement of the stakeholders, doing research in areas which directly benefit the people with lived experiences, and also a decision-making process, making it a shared decision-making to address the epistemic injustices. So this is a kind of an example that the ICMR, we already know the largest health research funding body in India, that floated an advertisement in the earlier part of this year that listed 54 conditions as priority conditions. Only 3 of these are mental health conditions, but how this list was generated, why was this generated, who all were involved, but not mentioned. The third ethical that I would like to talk about is research equity, which is about the fair distribution of available resources as per gender, socioeconomic status. Research equity involves community engagement, talks about accessibility of the interventions. Mental health research inequity grossly stems from social injustice. A classic example is direct association between poverty and mental illness, but important to note that policies that had equity at its core, for instance, in one of the Indonesian studies, direct cash transfer has been shown to reduce suicidal risk in the community. So equity helps. However, in the ICMR research evaluation criteria, equity does not figure, which is not aligned with our national health and mental health policy, which talks about universal access and talks about equity. So now coming to the recommendations, the first one is, of course, India is a diverse country, so there is a diverse need. ICMR has 31 regional centers, so they can collaborate with each other and come up with specific needs, region-specific needs, of course, including not only people with lived experiences, but also families. The social hierarchies must also be addressed to include people. The second recommendation is, of course, including equity as one of the evaluation criteria. ICMR has done this before for maternal and child health. Maybe the same can be extended to the mental health field as well. So finally, my key point is we need a transparent, inclusive, and equitable approach in the research priority setting in mental health in Indian context, and Indian Council of Medical Research, being the largest funding body, should take a lead by balancing between the resource constraints and the competing interests. Thank you very much.
Thank you very much, and keep your questions because we would have other opportunities to ask. Say 4,000 research ideas, that sounds like a treasure. The next speaker is Edward Kusewa from St. Paul University, Kenya.
Thank you very much. My name is Edward Kusewa from St. Paul's University, Kenya. I'll be presenting on Ebola response in West Africa. And basically what we've seen is that there were power imbalances between the high-income countries. Oh, sorry. Do I say start? Or do I press this? Start. Sorry, my name is Edward Kusewa from St. Paul's University, Kenya, and I'm presenting on the Ebola virus disease outbreak response in West Africa. What we saw is that there were power imbalances because of this Ebola virus disease. The high-income countries had a lot of impact for the lower-income countries. Most of these states were very fragile. Though it was an old disease in equatorial Africa, it was relatively very new in Western Africa. They were very fragile. Most of these states had very weak governance system. They had limited administrative capacity. There was still a lot of social tensions that existed in that ecosystem. Well, the delayed international response in West Africa was because in Congo in 1976 was infrastructure limitation, was what they were saying, that there was a problem with logistics, there was a problem of power, people could not reach the hospitals because of those factors. Well, some of the factors that contributed were quite a number of them, but I tried to put just a few of them which made sense. There was weak surveillance systems, social cultural factors in Africa, especially burial, weddings and so on and so forth, inadequate infrastructure, and so on and so forth. So the proportions of death by country, if you look at the three countries that were most affected, Liberia, Sierra Leone, and Guinea, was because of the factors that we've spoken about in the power imbalances. Within a very short time, there were about 20,000 deaths, and this was because there was very little international response. And this can be seen as some of the effects of lack of investment in research and development. So Ebola starts in March 2014. In July, about 15 to 17,000 deaths had happened. And these were the 10 key areas that brought about the power imbalances between HICs and LMSCs. We spoke about them yesterday in length: local health priorities, trust, transparency, accountability. We spoke about funding. Now people are mentioning capacity building, research agreements, and so on and so forth. The ethical issues that I'm going to speak were lack of representation. People were not given opportunity for decision-making. Communities were not involved. Vaccine were not put in time. So this was a whole factors that led to the explosion of the sickness. So lack of representation, development and distribution of experimental drugs, lack of transparency and equity in research prioritization. LMICs were underrepresented in decision-making processes for research priorities and resource allocation, in research agendas that did not adequately address the health needs. Again, there was exploitation of research participants, unfair power dynamics between HICs and LMICs led to exploitation of research participants. Again, there was control over funding. HICs may exert control over funding for research, which can limit the ability to conduct research in LMICs. And again, there was no investment in preparedness. There was no investment in emergencies. There was no investment in funding towards protective and safety gear for the people, especially the people in the front line. And that was a very big issue for people who are in the front line. So unbalanced distribution of benefits, including unfair power dynamics between HICs and LMI, resulted in unbalanced distribution of benefits from research, such as the development of new drugs or vaccines. So there was not a lot of funding. And then again, there was no compensation for researchers or communities in these countries. And my recommendation is that we need to increase LMIC representation. We need to prioritize ethical considerations, establish robust frameworks for rapid international response to outbreaks. And that calls for more equitable research prioritization and resource allocation. And then we need to address disparities around resources and protective equipment to safeguard their health and effectiveness in combating the outbreak. We need to prioritize timely and adequate assistance to mitigate economic hardships, address healthcare needs, and combat social stigmas. And emphasize community engagements and collaborations to aid in the recovery process, investment and involvement of local communities in research initiatives, ensuring culturally sensitive and community-centered approaches. Am I too fast for the slides? Thank you.
Thank you very much. Thank you very much. We went from India to Kenya and now back to Europe. Valerie Luyckx, did I pronounce it right? From University of Zurich, Switzerland.
Thank you. I'll try to speak. I'm a little bit, I'm wearing a mask because I've lost my voice, but I'm not feeling sick. So just to be 100% careful, hopefully everyone can hear me. So if we can start, please. So I will present research developed in the global north and being conducted in the global south, similar to a proposal on acute kidney injury that I reviewed recently for a big grant funder, which homes in on two specific questions which could be relevant, but may or may not be priorities right now. And so my question really is, how can we improve this process? So, now this does go a bit slowly. So the study basically is a young investigator from a high-income setting, previously did a small similar study in a neighboring country. She now wants to evaluate the performance of various possible new diagnostics for acute kidney injury in this new setting. Many are not fully standardized, and her focus is on snake bites, and also the input of the local investigators is not very clear. So in acute kidney injury, the global burden is really not known. As you can see here, the burden in low-income settings is presumed to be very, very high based on data from high-income settings. The mortality is about 1 in 10, and it's about the same as tuberculosis. But we really don't have robust numbers. If we look at the causes of acute kidney injury, there are many, many causes, and these are related to social determinants of health, especially in low and middle-income settings. If we look at envenomation, it's really a tiny microcosm of this huge problem of acute kidney injury. So the big question here really is it worth focusing on such a small question? Another big issue in terms of kidney injury in general is the leading cause of catastrophic health expenditure around the world, because it is preventable, it is treatable, but the treatment is extremely expensive. And so the big problem is, how do we prioritize acute kidney injury or kidney injury per se, because we think the burden is very high and the catastrophic expenditure is very high. But if we look at the fact sheets of the World Health Organization, this absolutely nothing about kidney disease whatsoever. So the question here is, acute kidney injury, as far as we know, is similar burden to other global priorities. If it is considered a global priority, should AKI be prioritized? And within AKI, what should be prioritized? So in order to make diagnoses, we need certain techniques, and there are basic techniques like a creatinine blood test that's not available at the primary healthcare level. So another question is, should we be investigating fancy new techniques in settings where even the basic techniques are not there? So very difficult to understand. So the question for me is, what are the obligations of the researchers? And the question here is, what should be the breadth of the study? Should there be clinical input if you are looking at a clinical problem? They will not follow up any patients. Should we be testing diagnostics in low-income settings when we could possibly test them in high-income settings? And should we be looking at costing? So a big problem in terms of the global research agenda is this issue of frequent flyers. We all know this. The research topics, the researchers, the institutions, the funders are all focused on certain things, as well as a lot of the research topics are the low-hanging fruit, which are the easy-to-answer questions and questions with simple solutions, but may not really be dealing with the major topics. And this was discussed yesterday as well. There's a huge disproportionate allocation of funds to in the global development aid for health, and we can see the major disease burden is non-communicable diseases, but over the last 20 years, only 2% of funding has gone towards non-communicable diseases, probably similar in research. I tried to find a database that was going to show where funding is allocated. As you can see, most of it comes from the global north. Some of it is done in the global south, but predominantly, really, global research agenda is being driven by the global north, and a lot of it is on problems that are happening in the global south. So it takes 17 years to get evidence into practice, and so we really urgently need to understand what are the global priorities so that we can start to develop solutions that we can then start implementing to try to improve global health, global level, with some equity lens. And so who should really be overseeing all of this? And I think we've discussed all this, the funders, institutions, the local or institutional ethics committees. Should there be expert reviewers for specific topics who can really understand from a global perspective? Should there be global oversight bodies like the WHO or somewhere else who has some sort of an oversight of the entire research agenda? So basically, in conclusion, I think the blindfolds need to come off, and we need to see the research agenda clearly. This is analogous to this concept of decolonizing global health. There's this huge elephant in the room of power and privilege. We need to acknowledge this, and we need to try to take off all the blindfolds so that we see the entire problem as it is and can address it holistically. And so finally, basically in 2021, when the COVID vaccines had been developed, were being very inequitably distributed. Antonio Gutierrez said we've passed the science test, but we are getting an F in ethics. And I think collectively we need to strive to get better marks in the global research agenda so we don't get an F in ethics for the research agenda. Thank you.
Thanks very much, Valerie. We go next to Central America. Gaki Masunga unfortunately wasn't able to come here, so we go to Central America, to Honduras. Guimel Peralta from Central American Technology University. And remember to say start.
Start. Good morning to everyone. My name is Guimel Peralta from Honduras, and today I want to share with you a work made with Dr. Tatiana Carozzo, a bioethical perspective about a neglected disease, the Mesoamerican Nephropathy, a chronic kidney disease endemic from southern Mexico to Panama, but it's not distributed equally. So who are the affected ones? It affects young, previously healthy men with low income and living in rural areas. There is no established cause yet, but as it has been clearly associated with strenuous working conditions, high temperatures, dehydration, and agrochemical exposure. Similar conditions have been identified in other low middle income countries, but the prevalence is higher in Mesoamerican region, up to 50%, due to the total absence of representation on the global north, and in the wealthy population of the affected countries, there is inequity in prioritizing the research. Mesoamerican nephropathy is the leading cause of death in young men in endemic countries, and yet there are just 75 studies in the last 5 years. On the other end, Alzheimer's disease, prevalent in high-income countries, has over 4,000 studies in the same time frame. The inequity and injustice is evident. So, what ethical challenge do we face in research? The affected population has no purchasing power, so research is not profitable for industries. Rural population has poor access to healthcare, and there is no medical records in digital, so there is no reliable data about the real burden of the disease. Particularly in Honduras, the available data is very poor, so it has to be excluded from some studies. Moreover, local governments don't prioritize health research. Also, we experiment a colonization of research. For example, in the last workshop, only one region researcher was present. So how to identify criteria and prioritize setting about Mesoamerican nephropathy? We can agree there are plenty of opportunities and direct benefits, such as less mortality, and indirect benefits, such as reduced economic burden on families. So why Mesoamerican nephropathy is not a priority yet? There are plenty of factors. The government prioritizes maternal and child health because they receive economic benefits if they reach specific goals. And we know that the affected population has no purchasing power, excluding a large sector of funding providers. And what about non-governmental organizations? NGOs use expert opinions as a prioritizing method in more than 80% of all cases over others. So if local stakeholders are not considered, priorities are not equally identified. This study has a very interesting approach. However, the study only included 2 of the 8 affected countries of the region, El Salvador and Nicaragua, and they only include 3 stakeholders in the realization of the study. So why it is important to include locals? A lot of reasons. First of all, we also have researchers to design and run studies. Also, we can propose priorities focused on the context of the country. For example, urine biomarkers could be a better option for diagnosis rather than kidney biopsy, not accessible for most of patients. Also, local researchers can spread education between the healthcare workers that are in contact with the population of interest. And local ambulatory are also placed for education. Educating people on the disease it's very important, starting so we can place the education and prevention and checkup. So what do we just suggest to overcome the problem? It is important to establish a Mesoamerican collaboration on the topic, starting a priority setting exercise for a region, which will seek together for funding and proposing well-designed, large and multi-centric studies. We are looking to collaborate with internal researchers, but local stakeholders must receive power in the priority setting. Also, we consider the James Lynn Alliance framework as a good priority setting in Mesoamerican nephropathy case, as it focuses on leaving freedom to local stakeholders on priorities. Finally, we recommend that all the process of prioritizing should be developed under an equity lens, as we must keep in mind that the population of interest, young working men living in rural areas with low income, will otherwise be excluded by researchers' coverage as they have been in the past decade. Thank you very much.
Thank you very much. We're going from Honduras to Mexico. Ileana Romero from Colectivo de Salud Mental, TLP, did I get it right? So she has more audience than most of us. She has 6 million audience, so please, come on, come.
Start. Hola, ¿qué tal? ¿Cómo están? My name is Ileana Romero Martinez, and I will share with you the ecology of engagement model. During the 2021 Global Forum of Bioethics in Research in Canada, the connection between stigma and discrimination towards people with mental health issues was emphasized. This event highlighted the pressing need to address these ethical and social challenges. In response to this, in March of this year, a seminar workshop was held in Mexico to address in an integrated the stigma discrimination complex. I participated in this seminar that focused on innovative strategies to overcome the challenges, acknowledge the ethical issues involving mental health research, setting a milestone for Latin America in understanding and addressing these problems. One of the most relevant aspects was recognizing the importance of linking family and community to promote equality and social integration in the context of mental health research. Community involvement has been seen as inviting outsiders into research, which implies the researchers decide who to involve and how to involve them in order to achieve the study objectives. Engaging community requires maintaining and sustaining an unbiased approach that recognizes the variety of voices and experiences to guarantee ethical and social just results. However, this is most often overlooked or simply not done. Perhaps it may be important for researchers to acknowledge and accept the existence of power imbalances in the decisions made during the research process, which affects the capacity of certain groups to benefit from the results. It's necessary to review models that offer a reciprocal perspective on participator leadership, ensuring the existence of real decision-making instead of a merely symbolic approach. The coordination among public, private, and nonprofit organizations makes it possible for resources to be globally better allocated and decrease the problem of wasteful research. From my experience as a person with a diagnosis of attention deficit hyperactivity disorder and borderline personality disorder, I have refused to participate in clinical trials because I think our participation should start in the planification phase of the investigation. I'm curious by nature, and the questions that are important to me may not be important for researchers. Research teams would have to be formed with functional individuals that have been diagnosed with mental issues, social organizations, caregivers, mental health professionals, and mental health researchers. It's a fact that people with lived experience or who have a diagnosis are actually the expert in their needs. And with the guidance of a lead researcher, the team can guide the study model, forms of evaluation, or questions that help meet research priorities. A group of researchers led by Jacqueline Bravo from Colombia and Paola Buedo from Argentina, as well as Telepe Mexico Collective, an organization I founded, have joined forces to prepare a research protocol with the ecology of engagement model and execute it between 2024 and 2025. This collaboration seeks the practical application of the model and its potential to establish real priorities in mental health research with shared decision-making. For this project, we will be using the definition of patient engagement from the Canadian Institute of Health Research. It's required of all the members of the research teams to be trained in methodological and ethical aspects to ensure the homogeneous and effective skills throughout the research process. With the partnership approach, we seek to achieve transformation from within through collaborative leadership, experience sharing, and partnership synergy. The guiding motto for this model is we research together, learn together, and promote mental health. In the current context of mental health research, ethical challenges arise to gain relevance due to technological changes, a globalized society, and a poor understanding of the ethics in research in this particular health field. Our intention is to delve deeper into these unanswered questions. Since the model to offer an integrated, adaptable, and fair approach to the construction of participation policies in the complex mental health ecosystem. Through this model, we aspire to foster authentic shared decision-making and a more diverse representation in research, thus contributing to more balance and a fair future in a mental health research. Thank you very much.
Our last talk is from Malaysia. Tengku Sasongko, I hope I didn't pronounce it wrongly, International Medical University of Malaysia. We're looking forward to hear about rare diseases. I don't remember to say stop.
Yep. I start? Thank you for the opportunity to present this case. I'm Teguh. I'm from the International Medical University, Malaysia. My case explores the ethical challenges associated with the prioritizing research on rare inherited diseases in lower and middle income countries within the context of Cochrane evidence synthesis. Rare inherited diseases are affecting 300 million people worldwide, and mostly are from LMICs. Only less than 3% of diagnosed RIDs have suitable drug treatment. RID research in LMICs suffers from challenges and limited resources, while there certainly are needs to actually answer unique questions reserved by RID situations in LMICs. In building evidence base, evidence synthesis uses formal and explicit rigorous methods called systematic reviews to bring together the findings of clinical studies. Despite reputation as a gold standard for evidence synthesis, there have been strikingly low representations of LMICs among Cochrane authors. After the pandemic, Cochrane suffers major setbacks in funding, which forces it to relook at its structure and operation. For example, Cochrane Cystic Fibrosis and Genetic Disorders Group transformed into Cochrane Cystic Fibrosis Group, which reflects the focus of funders on RIDs of the HICs. Nevertheless, Cochrane is trying out what it calls evidence synthesis unit and says it will build one in LMICs. One study, up to 2020, showed that 3/4 of Cochrane reviews were produced by HIC researchers. This actually raised questions about fairness in the evidence production. Selecting research questions for RID in LMIC involves careful consideration of limited resources and delicate balance between scientific rigor and addressing immediate patient needs. While gene therapy holds promise for treating rare inherited diseases, it may be prohibitively expensive and inaccessible for LMICs. It is also essential to consider the global and local settings in which RID research priorities are developed. International organizations and funding agencies typically situated in HICs might prioritize advanced therapies or genetic testing, potentially overlooking the basic needs emphasized by patients and providers in LMICs. While Cochrane has dedicated priority setting method group, representation of the LMICs in setting priority topics has not been well institutionalized. While the intention to establish LMIC-based ESU is appreciated, challenges are there. Scarcity of local resources, buy-in of the local policymakers, and also engagement with local interest groups. Challenges include inclusion and fair process, criteria and goals for selecting RID research questions, global and local settings in which RID research priorities are developed, and governance issues such as capacity building and ethical justifications for allocating scarce resources to RID. Review groups should reflect the diversity of stakeholders. Capacity building programs are required, which will promote the development of local LMIC expertise in evidence synthesis and to ensure that ethical justifications are in place for allocating scarce resources to rare diseases, besides involvement of local communities and stakeholders. Careful consideration of the ethical implications of different research questions and the potential impact of research on patients' lives is required. There may also be concerns about the cultural appropriateness of research questions and interventions of in LMICs, as well as the impact of research on local communities and cultures. However, building on local capacities in evidence synthesis requires investment in training program and infrastructure, which may be challenging to establish and sustain. What works in one country may not necessarily be applicable to another. Establishing involvement in LMIC stakeholders in the decision-making process may encounter bureaucratic resistance. As future prospects, increased global collaboration between HICs and LMICs can foster knowledge exchange. Investment in capacity building programs in LMICs can empower local researchers. Exploration of innovative funding models may alleviate the scarcity of resources in rare diseases research in LMICs. As closing thoughts, we need to emphasize the importance of embracing diverse perspectives and collaborations, highlight the ethical imperative of prioritizing rare inherited diseases research in LMICs, and stress the need for collective action and commitment from the global community. So finally, I want to express my heartfelt gratitude to each one of you for being part of this discussion. For those eager to delve deeper into this crucial topic, I welcome further discussions and collaborations. In closing, I extend my sincere thanks for the opportunity to share this research with all of you. Thank you very much.
Thank you very much from all of the speakers. Remember, vote again for your favorite talk. It was a lovely presentation. I hope you all enjoyed as much as I did. And after voting, you can also go for your coffee break. Thank you very much.